Yes, my name is Kenneth Pelletier. I'm a professor of medicine at the University of California School of Medicine in San Francisco, and my primary clinical orientation is preventive cardiology. And I have seen from the field of cardiology, which is advanced by leaps and bounds in the area of prevention, the value of preserving health and performance and productivity for individuals, and how we as clinicians can help individual patients, but also move into the corporate sector and into the government sector with programs that really do enhance and reduce the burden of the preventable diseases. My particular area of expertise or interest is in working in the private corporate sector. My research is with 15 of the Fortune 500 companies in a program I created at UCSF and also at the Stanford Medical School about 30 years ago called the Corporate Health Improvement Program. And what we do is we implement interventions in back pain, cardiovascular disease, cancer prevention, HIV prevention, stress, these various kinds of health hazards, and demonstrate clinical and cost outcomes that it in fact pays an individual to take better care of themselves, to prevent preventable diseases, and it certainly pays a dividend to the corporation or to the country to have that done. So with that in mind, I think what I really would like to do is emphasize the fact that for clinicians, the opportunity to work with employers, to work in the workspace, is really an unprecedented opportunity. If you look at the databases, the integrated databases on pharmacy costs, presenteeism, absenteeism, all of these areas, then you realize that this is in fact a lucrative place to practice what we do with an audience that's motivated and really and able to take our messages and really put them to use. Our research projects, particularly in the cardiovascular area, have been in looking at single factors like the development of programs to screen and prevent hypertension, excess cholesterol, and multifactorial cardiovascular disease, all of which have demonstrated clinical outcomes and cost outcomes. Another area where we do a great deal of work is in pain and the ability to use non-opioid approaches. In the United States, certainly there's a very strong emphasis on prevention as the cornerstone of the future of medical practice. I mean, quite literally, we cannot, in any nation, certainly not in the UK or in the United States, afford to treat the amount of disease that is evident in a growing aging population. As more people age, there's more chronic disease, more need for excessive testing, intervention, hospitalizations. Literally, we cannot afford to practice medicine in the way that we have, which is after the fact treatment of diseases which are by and large preventable. There was an editorial that I remember early in medical school in the New England Journal of Medicine by Franz Ingelfinger, who was professor of preventive medicine at Harvard and editor-in-chief of the New England Journal of Medicine. He had an article called the Role of Medicine, an editorial. And in that editorial, he stated very clearly, he said, let's assume that 80% of disease is self-limiting. Either people die or they get better by themselves with no medical intervention. In 10% of cases, roughly, medical intervention is dramatically successful through antibiotics or surgery or various interventions and treatments. He said, alas, in the final 10%, give or take a point or two, the result of our medical interventions are iatrogenic-related diseases, medical, pharmaceutical, drug interactions, unintended consequences of an intervention. So his conclusion was that, so when you look at the role of medicine in the creation of health, the tally is marginally on the positive side of zero. Now, for me, that was quite telling in 1974, and it's still true. And I think what we're beginning to recognize is that we know the preconditions for most diseases. We know about smoking, lack of exercise, stress, diet, environmental exposures, preventable diseases, preventable conditions like excessive speed, not using seat belts. So there's a great deal we know that about prevention. The trick now is how do we implement these things And more importantly, not only how we produce change for our individual patients, but how can we sustain those changes over time? And again, we're making progress with physician overseen coaching, where you help individuals set goals and have nurses or health coaches work with that person by telephone on a weekly basis, or even more often if necessary, to make and sustain changes. And to me, that's the critical element. I've had patients say, well, of course I can quit smoking. I've done it dozens of times. And that's true. Smoking cessation frequently takes as many as 10 to 12 attempts before the person is successful. So we know that that's an issue, and I think what we're beginning to learn is how can we help people make changes and sustain changes over time. And that's, to me, really the biggest challenge of all. So if I look into the future, one of my areas of research in the last 7 or 8 years has been epigenetic testing. And if we look at risk factors, risk profiles for, we're not talking about disease prediction. We're talking about looking at healthy biomarkers. You take the same technology, but you apply it not to predict a disease, which is only statistical and is only a probability, it is not a certainty. What we can do is look at biomarkers and give back to a person, get into our charts in a hospital or in a clinic, the fact that, as an example, cholesterol is within a narrow range. If it's too high, that's clearly a risk. If it's too low, that indicates perhaps a whole different set of diseases, cancers, etc. And what we can do by displaying that back to a person is saying, well, you're above or below this range. Here is what you can do to bring that within a normal range. If you think about all of our blood parameters, all of our genetic markers, we can do the same for all risk factors. And in doing that, we provide both the clinicians and the patient with the information they need to collaboratively make decisions about what to do. And we've done this with diabetic management, insulin resistance, hypertension, cholesterol, and cardiology, and it's applicable to many other medical specialties as well. So I think this represents a significant future. What we know is that genes do not change. Genes are invariant, but what does change is the expression, whether a gene is expressed or suppressed. You may have a predisposition to irritable bowel or heart disease or any number of host of other conditions, but unless you have the lifestyle-related triggers, the poor diet, lack of exercise, high stress, environmental exposures, that gene will not become manifest. You will not have that condition become evident in the course of your lifetime. On the other hand, if you do all the right things, you can have that disease remain, or that genetic expression remain dormant for your entire life expectancy. This is exciting to me because I think it opens up a whole new area of research and clinical practice. It'll make personalized medicine, the ability to give to an individual unequivocal information about what they can or cannot do to maintain their health, maintain their longevity. So this is probably one of the most significant changes, I think, the personalized epigenetic assays for patient care that we've ever had. So with that, I want to thank you and hope this information has been helpful. And I want to thank you both on behalf of the preventive system in the United States was evolving as well as here in the UK. So thank you.